Welcome to Family Focus, a program produced by Family Service Association. I'm your host, Mike Moran. We thank you very, very much for tuning in to this edition of the program. There's probably few subjects in the area of healthcare and general well-being among the population that gets more attention than the opioid crisis. And we are going to address that subject really for the very first time on this program. And recently at a general staff meeting at Family Service Association, I and about 100 of my colleagues get a chance to listen to remarks by our guest who is here today. And after we heard her, we said, well, we really do want to get Stephanie to come on the program. Stephanie Perry is here. She is an addictions nurse specialist and based at St. Anne's Hospital in Fall River. But we're going to learn a lot together today about addiction and about the opioid crisis in particular. Stephanie, thank you so much for doing the program. We really appreciate you being here today.
Thank you for having me.
Yeah. How did you, there's a story to how you got into this field, and I'd love to have you tell it because I enjoyed it. There's no other word when I first heard you tell how it is that you got into this field.
I think it's important to note that this epidemic, we're talking about it all the time. It's all over the TV, the news. You don't go a day without hearing about it or being affected by it. For me personally, I grew up in the 80s in a neighborhood that was ravished by heroin. Early on, this wasn't something new. It was new to my neighborhood at the time, where it seemed like overnight it just came in, and friends, family, mothers of fathers of my friends, they just were, like I said, ravished by this disease. And I learned at a really early age that there's a very big difference between the disease and the person. And I feel honored and privileged to have learned that at such a young age, and it stayed with me. So despite the transition in their lives or what they may have become, I was always very humbled to the fact that this was the person that once was or could be again.
And don't we often, particularly when it comes to addiction, we look at the problem and sort of divorce from it the humanity that you just described. These are people's sons and daughters and siblings, and they're persons that are suffering from an addiction, and there's an ease with which some people are quick to be judgmental about those who are in the throes of addiction. I'm telling you something you don't know. I'm sure you could write the book on how that occurs and all the reasons why it shouldn't.
Mm-hmm. I think for a long time that was an acceptable viewpoint. It's a choice. There was a lot less assistance out there. There were people that, it's over here, it's not my problem, it's okay. And now where we're at, as unfortunate as it is, we are fortunate in the sense that the community, the medical community, society in general are starting to look at it differently, and there's a turning point. Mm-hmm. And yes, this is about humanity. We are human beings affected by a disease process, and our behaviors shouldn't be judged based on where that disease process takes us. And we do it so very often. And when you're in a room with, and that day I was in a room with 100 people. I could tell you if people didn't have the shame or the stigma associated still, as far as we have come, if I would have asked honestly how many people could have been affected, I don't know how many hands would have showed.
Sure.
And that says something, because I work with people who are professionals in the community who deal with this every day, who call me and say, could you help me with my son or daughter? Right. They're suffering, and nobody in their world knows, in their professional world at least. Right. And that's kind of unacceptable.
We could talk about addiction endlessly, but with specific regard to the opioid epidemic, and you would characterize it as such. That's not a term that is designed to heighten the drama. We're talking the real deal.
Right.
How do you see, as a professional in the field, how do you see, if you do see, its origins? How did it come to be? Maybe the simplistic version is that doctors overprescribe medications, and they're very strong, and they're stronger than we thought they were, or they thought they were, and suddenly an addiction develops, and then people are scrounging around looking. This is the simplistic version of how this occurs. What's the story from standpoint of a professional, what do you think began to make this problem escalate to the degree that it exists now, as opposed to that simplistic version that I just described?
I think early on in this disease, the fact that the medical community probably wasn't looking at it as seriously as they should. It became a moral failing as opposed to a medical process. I think that was a very big piece.
How do you think we got here so quickly? Because the problem does seem to have escalated a great deal.
I think that the nature of the drug, for instance, this completely hijacks your brain. It decreases your thought patterns, the way your brain operates. So you're asking someone who has essential damage to their frontal lobe, right, which is your decision making and your processing system, to make rational, not impulsive decisions that are going to be the difference between life or death for them. Right, but they have a broken brain. So as much as we say it's a choice, really their choice or their ability to choose has been hijacked by the power of this drug. And it very quickly escalates. And yes, prescription drug abuse was a really big problem for a very long time. I think we're doing a fabulous job now with the prescription monitoring programs to decrease that. People aren't getting prescriptions like they once did. But what's happening is we still have a society that's been addicted who's transitioning to street level drugs.
Well, you're pointing to something which seems like an improvement. However, and I'm sure you hear about this. I know I've heard people say it just in casual conversation. They've had a surgical procedure, they've had an illness, and you know where I'm going with this. And gee, they gave me all these strong pills and I was fearful of them, so I didn't use them. I had pain, I used Motrin.
Right.
Is that still a fairly typical story, and what does that speak to in terms of, the re-education of the prescribers world?
Right. So now in medical school and nursing school, that's become a priority. Boston University is doing ongoing trainings with educating the prescriber, safe prescribing practices. So those things are decreasing, but it's still, we need to make it our business to know what we're putting in our body, right? So, and although a doctor may be handing us a prescription, it does not mean that that's the end all be all. And you must ask, when children, and it's repeated itself like you said, they're getting a simple dental procedure or they have a very common ACL injury and they get prescribed a boatload of opiates.
Sure.
And their doctor is saying, take them. And the parent, let's just assume it's a teenager, is saying, I'm going to listen to my doctor.
I'm going to listen to the doctor.
That's right.
And elders in particular.
Same, right.
Again, not to reinforce a stereotype, but there's a tendency that I've observed just casually, not scientifically, that elderly people tend to say, well, I trust my doctor. And if he or she tells me to do something, by golly, I'm going to do it. And I'm not suggesting that people ignore their doctor's suggestions or even their doctor's orders, but there's an educational component that needs to happen within the medical community as well.
Right, and I think the decrease in prescriptions has shown that that's actually, we've been heading in that direction. It's happening, but it's still important to know that, there's, instead of looking at, pain is a fifth vital sign, we don't, what the patient says it is, we need to identify studies that say Tylenol and Advil are just as effective.
Right.
What an opiate does to your brain, a prescription opiate, is it makes you forget you have the pain.
Oh my goodness.
It does nothing for the inflammation. It does nothing for the actual injury. It just affects the brain to make yourself think, I don't feel that pain anymore. The pain's not gone.
It doesn't deaden the pain in terms of what your nervous system experiences.
It does. It dulls the pain. But it's psychological. I don't want to say it's psychological because it does happen. But if I give you an anti-inflammatory, that anti-inflammatory is going to decrease inflammation.
Right.
Right? It's actually going to work at the site that the inflammation is building. It's decrease it. You're going to have less pressure, less swelling. You're going to feel better.
And I not to get too personal, but I've experienced that myself. The doctor said, you got a little bit of arthritis in that knee. Take some naproxen sodium, which is Aleve, and took 2 of those, and my knee went.
Yep.
And I felt better, overnight.
Right. And if I give you an opiate, your brain is going to send decreased signals to that area. So you're going to have the perception that the pain is less. And it will be, right? You will feel differently. But really, you're not physiologically changing the mechanism of injury per se. It's your perception of it. And what happens, and this is another problem, is people who take opiates for long periods of time, say they've been overprescribed or they've been on them for a long time, when they come into an emergency room, we ask them what their pain threshold, their pain is 0 out of 10, very common, I'm sure you've been asked.
Sure.
I'm never wanting to assume, but you can often assume that it's going to be a 10, if not greater. And that's because of something called hyperanalgesia. So again, back to the brain, it's completely affecting how your brain is perceiving pain. So your pain threshold changes, sometimes permanently, until those opiates are out of your body.
Right.
So a simple pinch, right? Let's just say, for a person who does not take opiates on a regular basis, maybe a 2. Somebody else might be a 5 because their brain is perceiving it at a greater. They have they have a higher sensitivity to pain.
Right.
And then what does that do? Makes you think you need more. So it's this whole circular process.
Sure.
That.
Wow. What you're saying springs forth a lot of thoughts. So I'm just going to toss them out there because I'm sure you can react to them. There was. This has been heard, and whether it's because people's experience sometimes with addiction may not be through their families, but stories that they see, documentary programs, films, that when it comes to, and this may apply to more than just heroin addiction, there are those who say that, that high that they would feel, that euphoric feeling that they had at the beginning of their experimentation with heroin, becomes less over time, and as maybe I'm perceiving it wrong, but somewhat rapidly, and then it's a matter of I use it because when it wears off I feel sick and I want to take the drug to stop feeling sick, and that high, that euphoric high, is no longer there. And you talked about the circular nature of it. Then it becomes I need to maintain, I need to get more, I need to do whatever it is I need to do to feel as well as I can feel. Is that at all accurate, or is that the movies talking to my
No,
head?
that's absolutely so. Not to get into too much of the brain chemistry, but once you are altering your dopamine levels, right, which is your reward center, which sugar, heroin, opiates, this is what it's affecting, right? So your very first high, per se, is something that you would hear many people who are living with substance use disorder are chasing, that feeling of complete euphoria, of numbness, if you have. And you ultimately, you're never going to get there, but what you are doing is you're completely decreasing your brain's level. Your brain is no longer creating the amount of dopamine that it should, to make you feel joy even, to make you feel like you want to participate on the level of everybody around you. So what you're doing ultimately is you are lacking this, you're craving this, your body's saying, I need this to feel well. I need this to feel human almost. And they just continue, and then the tolerance will develop and you need more and more, and then the dependence. And
that's the word that didn't come to mind, was tolerance for the drug and the effects of it. Stephanie, stay right there. We're going to take a short break. We're going to come back. We're going to talk more. Talk about the opioid crisis, and we're talking about addiction in general, and you're watching Family Focus. We will take a short time out and return with the second half of our program. Don't go away.
Hi, I'm Carol Nagel, President and CEO of Family Service Association. A lot has changed since the day when our agency began its long journey of providing services to our community. In the beginning, our mission was a simple one: to provide caring and helpful services designed to improve the lives of the individuals and families who live and work here. And while the programs we provide have changed over the years, and the problems facing the community have become more challenging, Family Service is still here 125 years later to answer the call. As we look to the future, we'll continue to work together with our many community partners and to find new and better ways to bring our services to those who need them. Whether it's providing a warm, welcoming learning environment for preschool children, offering professional counseling, or helping elders maintain their good health and independence, Family Service remains committed to the spirit of that very same mission of service that guided us when we took those few steps in 1888. Please visit our website and learn more about our agency, its programs, and our long history of service to the community.
Welcome back. You're watching Family Focus, and one of the great pleasures that we have in presenting this program to you, and right now we're on 15 affiliate stations, which is really kind of cool. We're also available on YouTube and on the Family Service Association website and Facebook page. You can find this program. And one of the great pleasures that we have is to sit across the table from our community partners and talk about healthcare and social service and those services that are administered here in our community, in the South Coast community. And we have one such person. Let's reintroduce our guest. She is Stephanie Perry. She is an addiction nurse specialist and based out of St. Anne's Hospital. Thanks for doing the show. We really do appreciate it. You're taking us to school on things in a very real way, in a very informative way. Many people, and I'm sure you've seen it or you know of it, I watched breathlessly the documentary film that was made about Cape Cod and the stories of young people who were in the throes of addiction, some of whom appear on camera and yet are no longer on this earth. And some of their stories, not to oversimplify it, but the young football captain, and there's his team picture with the helmet on one knee with the helmet under his arm, and he was a tower of strength, had a sports injury, had opioids prescribed, and went down that long slide. I don't know how typical that story is, and I know that you're probably familiar with that and other stories like it. I guess my point in pointing that out is that when it starts to hit the suburbs, then more people perhaps sit up and pay attention. And it's not just the stigma of those people, that category of people that are suffering from addictions that we kind of want to pretend don't exist. It's affecting every socioeconomic group, every age group. Just what is your reaction to that, Stephanie?
It's interesting you mentioned that documentary, because I think of all the documentaries I've ever seen, that is my least favorite.
Oh, good.
And I say this because, is it accurate? Absolutely. The chaos that they depict in that is very accurate. Unfortunately for me, the way that film was done, I think you start to identify with certain characters, not even characters, well, certain people, real people in this documentary, and then you see that same person do something that to another person you've identified with, you know. And there was one really harsh scene where one of the kids that I know was very easy to relate to was injecting another young girl in her neck. And for me, I said, see, now that they're going to take that and any shred of anything that they got from this genuine kid who was sharing his story, who's just as sick as that girl, is going to be said, oh, see what he did, or see. And for me, I just found that to be unfair to the real life people in that documentary.
That elected to be a part of that film.
Yeah, because I think they were being blatantly honest and sharing in such a vulnerable way that you, at least for me, couldn't help to identify with them. But then when you associate it with the behaviors the way that documentary
so
did.
Do you feel that their stories were kind of exploited, that they as people were exploited?
No, I think they signed up for it. And I think, again, it's an accurate depiction. I just think that there was no hope in that documentary.
Okay, yeah.
There's another one, it's called Chasing the Dragon. I think it was by PBS. That's an amazing, and now it's just as chaotic, it's just as real, but it shows a lot of the care providers and the people who are doing the groundwork, who are really trying to connect to the services and connecting, even if the person doesn't want services, to that individual on a street level. So for me, I think it's very important that people understand that this is where it takes people, but you also have to give the hope. Because if not, what do? We get stuck in stigma.
Well, I'm so glad you said that, because that gives me a different perspective on that. And having not seen the one, although now you've piqued my curiosity to seek it out. So let's talk about, how is the medical community, how are you and your colleagues doing? I know that there are task forces in town, and there are those who try to combine their forces and their talents to try to address this addiction problem. I guess a very broad general question, how are we doing?
I think we're doing much better. Yeah. I think that Governor Baker has pushed some initiatives forward that are amazing. You know, the prescription monitoring program was one of them. Bridge programs. So a bridge program is recommended for all, and I think actually maybe becoming mandatory for many hospitals. And so basically if someone walks in and says, I'm in active opiate withdrawals, I don't want to use anymore, and I want medication-assisted treatment, or medication-assisted recovery is now the term we're using, which would be a Suboxone, a Vivitrol, methadone is one of them. But within an emergency department, we would deal with Suboxone. So it's something where we could give them a small 3-day prescription and connect them to a provider who could continue that ongoing. So that sometimes is the difference between someone leaving our emergency room or any emergency room and going out and using illicitly and potentially dying, or maybe they had one slip, but they need that assistance and it's not there. So those are things that now are in place. So those are great.
Not to interrupt, but I will. There are things that are in place that a short time ago were not?
Absolutely.
Yeah.
So South Coast is already doing it at both facilities. St. Anne's is in the last stages of facilitating that process so that you could walk into an emergency room. Of course, every story needs to be heard. We're not going to be there just to give out 3-day prescriptions ongoing. Sure. But we are going to work really hard with the individual to get them to the services they need. So that's one thing. There's a big push within Steward to really educate. We've done 2 educations. Dr. Jeannie Bailey, who's an expert in this field from STAR, has gone to the primary care doctors, who are the people who take care of our patients, and really given them an MAT, medication-assisted treatment, do's and don'ts, Q&A, and really got them to really open their minds and say what once seemed very scary to you is quite simple, and we're pretty much ethically responsible to care for the whole being. Mm-hmm. Not just, oh, you have diabetes and CHF, okay, we're going to care for that, but oh, your addiction, sorry. You know? Yeah, so... those things are starting to change.
And you're pointing to the stigma that's often associated with it, or the sense that some people have of the hopelessness of it, and maybe they don't know the success stories of people that have achieved recovery and have maintained recovery.
Right.
I'm very curious, in your position, do you get to see enough of that?
Absolutely. So that's what drives me. Right? I mean, I want to help everybody to get to where they are and maybe a little better than when I found them. That's my motto. Mm-hmm. I'm not here to fix people. I can't fix people. I can make them feel like they're worthy of being fixed. Mm-hmm. And that's something that I think in our hospital we've worked really hard on stigma and changing that perception and knowing that you might not get it, but get it for somebody who loves that person, or give it to a nurse who does. And we're doing a really good job of that. So for me, like in order for me to do this work, because it is difficult and it's daunting and there's a lot of sadness that comes with it, but when you actually see someone who has obtained recovery, you know, I enmesh myself in the recovery community, and we have a very strong recovery community here in the city. Peer-to-peer recovery project, mm-hmm. River to Recovery, the people that I stay in touch with, that I've worked with, it's a beautiful thing, and I can only compare it to, say, someone who has cancer and they've gone through treatments, life and death. We basically bring an oncology patient to the brink of death and to kill that cancer, and they come back with a whole new insight, right? So it's very similar for someone in recovery. They were living life, playing Russian roulette, as if they were dying every second of that day, you know? And then when they reach and they find recovery and they embrace it and they work a solid recovery program, they have this humility about them, this insight that we could only be fortunate enough to have. And I don't care if my education is what it is and someone may have not even a GED, they have more insight often to humanity and to what it takes to be strong than I do myself. And that's a beautiful thing that carries you a very long way. So for me, yes, I do see it. You know, and we are doing something within the hospital. It's a spiritual pillar movement where we're bringing one of our actual patients who had been, I watched this patient go from just dabbling with prescription medications to snorting them, to injecting them, to using fentanyl, to overdosing and nearly dying in our ICU, to having his mom Section 35 him. He went into mandated treatment. This young man has been sober for going on 10 months. He's got a job. He's the supervisor of his job. He just got his apartment. He's coming back.
Things that may have seemed like an impossibility
Absolutely.
at one point.
So he's coming back to share that with the same people who cared for him, but on a bigger scale, to say, look, this does happen. Don't give up. And it is hard, you know, especially in an emergency department. It's not perfect. You know, I was an emergency room nurse for a really long time, and it's hard when your patients come in over and over and over and over. And sometimes the behaviors of someone who's just been Narcaned, which is the drug that saves people's lives and reverses an overdose, are not what you want to see. They're angry, they're sick, and it's hard to care for them. So it's very important that we bring recovery to the staff.
What's the best thing for a person whose interest in this subject has been triggered by your remarks watching this program? What's the best place online for them to go to learn more? Would they go to the St. Anne's Hospital site? Would they go somewhere else? What would you recommend? Because you're sharing a lot of educational information here.
There's so many great community partners. One of the community partners is Recover Fall River. So they're the people that run the Overdose Awareness Day, the actual vigil at Government Center. And monthly, I don't know if people know this is very important, that on the third Thursday of every month at Government Center, there is a help center. So that's treatment on demand, that's wherever that patient is or a family member is. And every month they have a guest speaker who actually, you know, it might be Narcan one month, it might be medication-assisted recovery the next month, it might be a family support group the next month. So there are resources that are ongoing on a monthly basis that people can tap into that unfortunately don't always know that are there. But that's a good place to start because everybody's in one building under one roof every month.
I can't thank you enough for doing this program because I think, you know, to see the level of expertise that exists, perhaps out of necessity, in a community like this is comforting, and it's good to know that if there are people that are in families, it doesn't, you know this better than anyone, it isn't just the addict or the person suffering addiction. The impact on the families and the ripple effect throughout the community is enormous. But there's hope. There
is hope, and we just need to be kind and meet people where they're at. And lower the expectations of what you expect of someone who's sick. You don't expect a diabetic to not want to eat cake, right? You don't hate them when they lose a toe because they ate too much cake. It's kind of the same when someone is living with this disease process. Be respectful of the fact that it's a struggle every second of that day.
See that, viewers? You met a good person today. Stephanie, thank you so much.
Thank you so much.
We appreciate you being on the program.
Thank you.
And we thank you for all that you do. And we thank you for tuning in to Family Focus. It's been enlightening, and we thank Stephanie Perry for joining us today, and we hope that you will tune in again next time when Family Focus comes on your screen. Thank you so much. Bye now.